All right, good afternoon, and thank you so much, Dr. Sullivan, for the very kind introduction. It's always a pleasure to work with you in taking care of our transgender patients. I'm sorry I couldn't be here in person today, and I want to thank the organizers for their great efforts and also for inviting me to speak on this important topic, which is the increasingly common question of the hematologic concerns in the transgender patients. My name is Dr. Yazan Abu Ismail. I'm a classical hematologist at the University of Utah, and I particularly have an interest in disorders of hemostasis and thrombosis, as well as LGBT health. So the objectives of my talk today would be to learn the evaluation and management of secondary erythrocytosis in individuals on testosterone, and similarly those of thrombosis and those on estrogen, as well as how to recognize and safely manage the risk-benefit of gender-affirming hormonal therapy in those with hematologic concerns. I don't have any financial disclosures. And the outline of my talk today, so the first half of my talk will focus on erythrocytosis in the patient on testosterone and the causes of that, how to evaluate for that, the risk of thrombosis with erythrocytosis and with testosterone, and then some specific issues such as iron deficiency and the use of phlebotomy and the overall management approach. And the second half of my talk will be about estrogen and thrombosis and the role of or the risk of thrombosis with estrogen and data on transgender patients and my specific management approach. So a little background. So therapy with cross-sex hormones or gender-affirming hormonal therapy may cause certain hematologic complications, and we'll go into a little more detail about that. But the most common things we worry about with testosterone would be secondary erythrocytosis, and with estrogen, it's thromboembolism. So it is important for the clinician and the hematologist to recognize and understand those risks in order to properly evaluate them and properly manage them and counsel patients on these potential risks and benefits and discussing options. Now, a common theme in my talk today, which I'll be reiterating, is that unfortunately that data is lacking. So in the transgender population, there's a severe paucity of data when it comes to understanding the hematologic anomalies as well as how to manage them, which means that most current practice and expert opinion is based on either extrapolation or low quality evidence or observational data, which is okay. I mean, observational data and extrapolation is useful, but we have to also recognize that it has its limitations, that in certain cases it may be theoretical or perhaps even experimental. And so we need to counsel our patients on these facts and often need to use our best clinical judgment and shared decision-making when making these management decisions. So I'm going to begin by discussing testosterone replacement and erythrocytosis. So a little bit of background on this topic. So a little bit of refresher. So red blood cells, or erythrocytes, contain about 250 million molecules of hemoglobin. Each is made of 2 alpha and beta chains, and each is bound to a heme group containing an iron molecule. In our CBC, the hemoglobin measures the concentration of hemoglobin in blood. The hematocrit measures the percent of blood volume made of blood cells, or in other words, the red blood cell count multiplied by the MCV, or the width of the red blood cell. An important distinction to make is that thrombosis risk is that is associated with higher hematocrit as established in polycythemia vera, but not other conditions that lead to a higher hematocrit. So in polycythemia vera, we know that a higher hematocrit is a thrombotic risk, but not for other causes of higher hematocrit. And to be very specific, polycythemia vera is a clonal myeloproliferative neoplasm that is caused by a JAK2 mutation, and it is confirmed when that mutation is identified on testing and ruled out when the JAK2 mutation testing is negative. So this is a very distinct entity and a very distinct disease, and a higher hematocrit in that condition, it does not equate to higher hematocrit from other conditions, and we'll get to that in a little bit. I will be using the term secondary erythrocytosis for most of my talk to refer to erythrocytosis that is caused by other reasons. Which leads me to my next slide. So what can cause erythrocytosis. And as you can see in this diagram here, that there's many different reasons that can lead to secondary erythrocytosis. So first, if we look here on the, so the top three arrows are things that are generally common in the population, while the lower three are much more rare. So first things first, relative erythrocytosis could be an artifactual thing. So if someone is volume depleted, is dehydrated, has been on diuretics, or is vomiting, had diarrhea, sepsis, so on, all of these things can lead to a relative erythrocytosis due to hemoconcentration. And then medications, so testosterone is one of them, as well as glipizides. So this is something to also consider in these patients, as well as erythrocyte or erythropoietin stimulating agents, such as epogen or darbepoetin. Hypoxia is the most common cause. So we do know that there's various reasons of hypoxia that can contribute, that can lead to erythrocytosis. And the reason is due to hypoxic signaling in the body. So anything that causes hypoxia and leads to the hypoxic signaling will lead to a physiologic response that increases erythrocyte production and erythropoiesis, and thus lead to secondary erythrocytosis. And you can see this big circle here because this is how many reasons there are, and this is how common it is. So this is sort of a reflection that the majority of secondary erythrocytosis is due to other reasons. So pulmonary disease, smoking, obesity, sleep apnea. Here in Utah, and I underlined high altitude acclimatization because it's a very frequent referral. Cardiovascular reasons, renal reasons, endocrine reasons, and so forth. And then much less commonly are the neoplastic or clonal erythrocytosis due to polycythemia vera I was mentioning earlier. And then there are congenital and hereditary mutations that cause erythrocytosis, which are also generally prothrombotic. And lastly, there's EPO secretion. So certain tumors may either produce EPO themselves or promote the production of EPO, such as renal cell carcinoma, paragangliomas, hepatocellular carcinoma, and others. So the first thing I want to address is, so what are the hematologic effects of testosterone? Secondary erythrocytosis is the most well-established and the most frequent. And we do know that data on testosterone use in general shows that it's a dose-dependent effect. And in transgender men, it's about a 10 to 20% incidence of erythrocytosis that occurs after starting testosterone replacement. It is highest in the injectable form and less in the transdermal form. And the mechanism isn't fully understood, but we do think that testosterone either increases EPO production or increases sensitivity to EPO, and may also lead to more iron absorption through reducing hepcidin. Although conversely, we may find iron deficiency in these patients because of increased iron utilization for erythropoiesis. So despite the increased absorption of iron that may occur, the higher turnover and the increased rate of erythropoiesis and the higher utilization of iron that occurs in that process may sometimes lead to iron deficiency. As for its effect on coagulation, biochemical studies have shown mixed type of picture. So it may increase platelet aggregation and may increase circulating estrogens that in turn may increase hypercoagulability. But at the same time, it may suppress tissue factor, which initiates the extrinsic pathway for thrombin generation, and may also have a protective endothelial advantage. So all in all, the net outcome when it comes to coagulation in biochemical studies is mixed, which will also correlate to the clinical outcomes that I will get to in a bit. So when it comes to understanding the hematologic concerns of testosterone in the transgender patient, there's a few questions that here we need to kind of answer and look at this roadmap. So first, we know that there's other causes of secondary erythrocytosis. And I don't know if you can see my mouse here, but these can lead to erythrocytosis. And whether secondary, so the first question is, does secondary erythrocytosis lead to thrombosis? Then we know that testosterone leads to erythrocytosis. So does testosterone leading to erythrocytosis, does that lead to thrombosis? And the next question is, does testosterone itself, with or without developing erythrocytosis, does testosterone on its own have a procoagulant or thrombotic effect as well? So these are kind of the three main things that I will try to address today. So beginning with things that we have more data on. So secondary erythrocytosis and the risk of thrombosis. In very old studies, perhaps like in the 60s or so, there used to be some earlier data that suggested that a higher hematocrit meant higher risk for thrombosis. However, back then, these studies did not make a distinction between PV and other causes of erythrocytosis. So this is probably in part why there's a general conception that or maybe misconception that secondary erythrocytosis is a thrombotic risk, but later studies seem to suggest otherwise. So kind of going on the available literature that we have, so there's been mixed results, but nothing that's been definitively that has definitively demonstrated a thrombotic risk. So a frequently cited study is the 1974 Framingham study, where the hematocrit, a higher hematocrit was associated with stroke risk, but then that risk disappeared in the multivariate analysis. And then a later study in the 90s showed no increased stroke risk in normotensive men, but it was seen in those with hypertension. A study that identified an incremental increase of thrombotic risk with hematocrit, the Tromsø study, didn't really comment on evaluating for PV either. And then a more recent 2012 study that was a case control study identified a 20% risk of thrombosis versus 14% in the controls with a p-value of 0.42 that was not statistically significant. Another study looked at risk of thrombosis in those with COPD and pulmonary hypertension that did find a higher risk of thrombosis or a high risk of PE, but did not control for things such as smoking or the cause effects of the erythrocytosis in these patients who do have a chronic hypoxic condition that may correlate with thrombosis. Now, I was mentioning earlier that SGLTs, are frequently used, more frequently used in diabetic care, and these have been shown to cause erythrocytosis. And I find this study to be relevant to our topic today because this is a medication-induced erythrocytosis, although perhaps through a different mechanism. So very recently, a couple months ago, Ganget et al. Did a study, published a paper on SGLT-associated erythrocytosis. And what they found in that study was that neither baseline hemoglobin and hematocrit, nor peak hemoglobin hematocrit, nor hemoglobin and hematocrit at the time of thrombosis showed any significant correlation with thrombotic events in that population. So in those with SGLT-induced erythrocytosis, the numbers did not correlate with thrombosis, not at the baseline, not at the peak, and not at the time of the event. Similarly, they looked at that data and to see which patients underwent phlebotomy, and they did not find that phlebotomy was beneficial in that population and did not appear to mitigate thrombotic risk. In fact, the numbers suggest that thrombotic rates were actually a little higher in those who underwent phlebotomy. So from that specific study, the authors conclude that the secondary erythrocytosis did not correlate with thrombotic outcomes, and addressing that with phlebotomy did not help either. Now, you might notice, one thing to keep in mind in these mixed earlier data where there was some thrombotic risk in some papers or others, is that it's not necessarily a causative effect. So those who did have a higher hematocrit may have had an underlying condition that led to that. For example, they may have been smokers. They may have had pulmonary hypertension that led to perhaps a higher thrombotic risk. They may have had obesity or other risk factors for thrombosis. So again, correlation isn't necessarily causation. So, but at least in overall, based on the available data that we have, there really isn't any convincing evidence that a higher hematocrit due to secondary erythrocytosis, particularly that that when it's physiologic due to hypoxia is a thrombotic risk on its own. And in comparison with polycythemia vera, there is a clear distinction. So I highlight 3 studies here that did show that the percent of incidence of thrombosis in those with secondary erythrocytosis is definitely lower than those who do have polycythemia vera. So we are still able to demonstrate that distinction between the two. So in other words, the thrombotic risk of a higher hematocrit is established in PV, but not secondary erythrocytosis. Similarly, the therapeutic benefit of lowering the hematocrit with phlebotomy is established for PV, but not for secondary erythrocytosis. Same thing for the use of aspirin as well. So when it comes to secondary erythrocytosis in general, how do we manage that? What do we do about patients who have a higher hematocrit? And that's in the general population, regardless of the cause. This is still an area of variable practice and a debate and some controversy. We do see some providers who do still implement phlebotomy, maybe use aspirin, and others who don't and just do observation alone. And a lot of this, comes from the concerns from polycythemia vera, although the evidence for secondary erythrocytosis is not is lacking. So what do the guidelines say? So I highlight here a couple guidelines that I think are most relevant to our topic today. So the British Society of Hematology in 2018 said in patients who do have secondary erythrocytosis, first of all, work up to identify the cause. So look for primary causes such as polycythemia vera and secondary causes, and confirm the findings. So this could be a relative erythrocytosis. So do make sure that this is a persistent finding by repeating the test at another time. And then in certain cases, consider genetic testing when there's a concern for a hereditary component. And management-wise, they say aspirin if otherwise clinically indicated for primary secondary prevention. So not necessarily for this purpose. They do not recommend cytoreductive therapy. And then venesection or phlebotomy in select cases, tailor the target based on thrombotic history and risk factors. So they don't give a number, they don't give a strict guideline about it. So it's kind of more of a vague consideration. Now, when it comes to the use of testosterone in those who have a higher hematocrit, the endocrine 2018 guidelines consider a hematocrit of greater than 50 to be a relative contraindication to TRT initiation, and this is for high altitude locations, and 48 for lower altitude. And for those who are on testosterone and develop erythrocytosis, they consider a hematocrit of greater than 54% to be a reason to discontinue testosterone or start phlebotomy. And again, as a reminder here, this is based on low quality evidence, so these are not strong recommendations, but they do remain part of many providers' practice. So the next thing I want to address is, does testosterone itself cause thrombosis? And this is with or without its effect on erythropoiesis and causing erythrocytosis. So in 2014, the FDA did issue a warning saying that testosterone could cause blood clots. However, if you do read that same document, in that same document, they cite the following studies as a reason for that warning. And if you do look at these data, the data is very weak and very mixed in general. So the ones in red are the ones that did show some harm. The ones in green either did not show a harm or a potential benefit. So very briefly, one study showed that there may be an increased risk of the composite outcome of MI, stroke, or death with a hazard risk of 1.29. Another one identified a relative risk of 1.3 for non-fatal MI. And these are all the studies that were included in that FDA guideline. And so that's all prior to 2014. And then another study they acknowledged suggested that it decreased all-cause mortality. And another paper also suggested it may decrease all-cause mortality. Another one identified no difference in MI. Another one identified no increased risk of CV events. And another one identified some risk of cardiovascular adverse events, but had methodological limitations. So the authors of the FDA announcement do acknowledge that this is a weak signal for cardiovascular risk, and however, to inform patients of potential risk due to the mixed nature of these results. Now, since then, we've had more studies and we've had more data that seems to more strongly suggest that this correlation between TRT and venous or arterial thrombosis is really very weak, if not perhaps non-existent. So I highlight the three largest ones that have been done since that warning have been issued. The one by Ergon et al. In 2015 had about 7,000 patients from a commercial database, and they found no increased risk of VTE with an adjusted odds ratio of 0.9, regardless of route of administration. And then another one that had 1,300 patients similarly did not identify a significant risk, except in those who did not have hypogonadism, and that was in the first 6 months. So in that study, the only patient population that seemed to be at risk were those who did not have hypogonadism, and that only happened in the first 6 months. And then another study in 2016, which had a large sample size of 10,000, also identified no significant risk of thrombosis with TRT use. So, in conclusion on that, the risk, the data that suggests that may suggest that thrombosis with testosterone is a concern is very limited and old and weak in general. So we don't really consider there to be any strong, convincing evidence to demonstrate that testosterone on its own is a thrombotic risk, in contrast to estrogen. So, so what about the transgender population? So, as I mentioned earlier, data is also unfortunately lacking. So there's very few studies that look at testosterone use and thrombotic potential in transgender patients on testosterone. And there haven't been any randomized or prospective studies that have documented it, that have looked at this, but also none that have identified a clear risk of venous thromboembolism with TRT. There are a couple of studies that looked at the incidence. So the one by Defrain et al. Identified an 11% risk of developing erythrocytosis. In that specific study, no patients developed thrombosis. And another study that was published a couple of years ago also showed a similar number. So 11% of patients of transgender men on testosterone developed erythrocytosis. They don't really comment on thrombotic risk in that study. And the more recent paper also looked to study whether there were any biochemical procoagulant changes in transgender men on testosterone, and they did not identify any, but they did in trans women, which I'll get to in the second half of my talk. So to wrap up the secondary erythrocytosis and testosterone part, so in conclusion, there isn't really any strong convincing evidence that secondary erythrocytosis causes thrombosis. However, we don't really know about extreme levels. So what is that number where we start to worry? Is it 54%? Is it 60%? Is it 65%? So we still have some data lacking for these extreme numbers to say, okay, we generally don't think that secondary erythrocytosis is a thrombotic risk, but what about extreme levels of it? So that's one thing. The other thing is that the basis of this conclusion is from a different population, and a specific cause of erythrocytosis. So in other words, different causes of erythrocytosis, medications, hypoxemia, and so forth may correlate with different outcomes. So that's again another limitation here. So we don't have an obvious study that looked at testosterone that led to erythrocytosis in transgender men and followed them long term. And this is in contrast to neoplastic and congenital causes that are really the only causes that have definitively been shown to be prothrombotic. And again, no obvious evidence that testosterone itself is prothrombotic. There may have been some mixed earlier data in the earlier 2000s that may have led to an FDA warning, but more recent data suggests against this. And while there is no good data in transgender patients the above concepts can be extrapolated to help us best manage and counsel our transgender patients. So a common question that also arises is, okay, should we phlebotomize these patients? Should we phlebotomize transgender men who are on testosterone and develop an or a hematocrit that becomes too high? So in secondary erythrocytosis in general, no evidence to support that this is beneficial. And the earlier study I noted for the SGLT-associated erythrocytosis also did not show a benefit and potential harm. So there hasn't been any reason to demonstrate that it's helpful. In fact, it's very possible that doing a phlebotomy may not even reduce the hematocrit to begin with. So a very interesting study that was done in 2017 showed that in patients on TRT who were undergoing phlebotomies, almost half of them did not have a change in their hematocrit to begin with. So it's very possible that the phlebotomies aren't really doing much, which also makes sense because as long as the erythropoietic drive is ongoing, the body should be able to recover unless it becomes severely iron deficient as a result of the phlebotomy. So that begs the question, are we treating ourselves as physicians when we make that recommendation? Now, that being said, there may be some symptomatic benefit. I do have patients who complain that, with higher hematocrits, they can feel it. They can either feel headaches, they feel dizzy or fatigue. And then after getting a phlebotomy, they transiently feel better. They can tell a difference. And I think, that may be a potential consideration, keeping in mind that also overdoing it, so doing too many phlebotomies or unnecessary phlebotomy can cause iron deficiency, which may ultimately on its own cause symptoms of fatigue, even in the absence of anemia. And we do have some early data that suggests that severe iron deficiencies are also on their own potentially procoagulant. So you don't want to cause a problem when there wasn't one to begin with, just to address the number of the hematocrit. And so this leads me to the next issue, which is iron deficiency. So from experience among my patients, as well as Dr. Sullivan's patients that we share together, we do know, and other data as well elsewhere, we do know that trans men may often have iron deficiency, even in the absence of menstruation. And this is possibly due to the increased iron mobilization that occurs as a result of testosterone. And there's an increased utilization that is happening as a result of heightened erythropoiesis. So higher erythropoietic drive and increased sensitivity to EPO, ultimately leading to increased iron mobilization and utilization that may ultimately cause iron deficiency. So what do we do? Do we replete iron when it's deficient? Now, in the general population, so those who are not on hormonal therapy, we do generally replete iron, even in the absence of anemia, because iron deficiency itself can cause various symptoms and may also be a potential cause for the patient to later on develop anemia. However, in trans men, iron repletion is likely to worsen erythrocytosis if they had erythrocytosis to begin with, or maybe like borderline normal. So, and thus that may also worsen any symptoms of erythrocytosis that may have, or any possible thrombotic risk if they have severe erythrocytosis. And like I said, on the other end, severe iron deficiency can also cause its own symptoms, can also cause fatigue, and perhaps be a thrombotic risk factor on its own. So what do we do in these patients? I generally avoid repletion if there is erythrocytosis in transgender patients on testosterone. However, it's not an absolute no, it's not a contraindication. So cautious repletion can be considered in specific scenarios. For example, if they have a severe symptomatic iron deficiency, and we're talking here ferritins and transferrin saturations in the single digits, that may be reason to consider very cautious and gentle iron repletion. And that is with the assumption that they do not have erythrocytosis, or their erythrocytosis is very mild. So we have some room to cautiously replete iron without causing a significant rise in the hematocrit, which would be the main concern. So if with a lower iron level, their hematocrit is already normal or slightly high, the assumption is that if we give even more fuel here. If we give more iron, that number is going to rise. So that's the main concern. So if iron is being considered, I do usually very cautiously monitor both parameters, iron levels and hemoglobin and hematocrit. Also, I would not consider that if the patient has any underlying thrombotic or cardiovascular risk factors, where I would worry that a severe rise in the hematocrit would be a problem. And I generally avoid IV and go with PO because it allows for a more slower and gradual repletion, where we could cautiously monitor and perhaps reverse course if we're noting that the hematocrit is rising. So to wrap up this half of my talk on erythrocytosis, testosterone, and transgender patients. So this is my general approach to the transgender patient on testosterone with persistent erythrocytosis. So first things first, I evaluate for any alternative causes of erythrocytosis and address if any. And this is the diagram I used in the earlier slide. So I do look for other causes such as pulmonary disease, sleep apnea that could be treatable, cardiovascular causes, smoking, and so forth. And I do consider testing for polycythemia vera if there's reason, if their numbers do raise a concern for it. And then I look at other medications. So are they on a SGLT? Are they on a ESA for any reason? Erythropoietin stimulating agent, and consider that in the evaluation. If there's anything that can be addressed, then that's great. If we can reduce causes for hypoxia and ultimately lead to a better number profile, then that would be great. I also assess them for any cardiovascular risk factors that should be addressed or reduced, things such as hypertension, diabetes, obesity, dyslipidemia. And then I assess for any symptoms that their erythrocytosis is causing them. So is it just the number that's elevated, or is it really causing them some sort of symptomatic harm or potentially a cardiovascular harm if they have underlying risk factors? And I do always pay attention to iron studies, and I always check them from onset and generally follow them. So after doing that initial assessment, if they have a persistent erythrocytosis, then in conjunction with their hormonal therapy provider, we consider testosterone dose reduction if their levels allow for that. So if they're well above the physiologic male range for testosterone and we have some room to go down, then that's a consideration versus trying an alternative route. And so instead of doing injections, doing things such as transdermal, and then reassessing for a change in the next few months. Now, if even with all these measures, so we've addressed underlying or secondary causes for erythrocytosis, we've done all we can with the testosterone dosing. If they have a persistent erythrocytosis, what do we do then? So generally, if the patient is asymptomatic and has low cardiovascular risk profile and a low thrombotic risk profile, and the erythrocytosis is mild to moderate, I generally just observe. I don't do anything about it. Now, a common question that comes, okay, but how much is too much? What is mild? What is moderate? And unfortunately, there really isn't a magic number. The Endocrine Society uses 54 as that kind of cutoff, which I generally go by. But again, this is based on low evidence. There isn't reason to think that, if they're 55 or 56, that's necessarily more of a problem. So I do generally kind of consider their baseline risk factors, any symptoms in making that determination. And if they're generally asymptomatic and a low risk type of patient, then I may not strictly adhere to any specific number as long as it's in the perhaps low mid 50s. Now, are there cases where I do consider phlebotomy? There are. So number one is if it provides symptomatic benefit, because I do think that's probably the only indication where it is actually helpful to the patient. So if they feel better and they have symptoms related to higher erythrocyte count, then it may be beneficial. I do consider it in those who have severe erythrocytosis. In the hematology clinic, we tend to have we tend to worry less about higher numbers, so we have a higher threshold. So I generally don't start to panic until perhaps in the 60s, but perhaps my colleagues may consider lower numbers to be severe. And I do start to make that a serious consideration if they have significant cardiovascular morbidity, such as severe hypertension, uncontrolled diabetes, uncontrolled dyslipidemia, morbid obesity, and so forth. And I would only implement that as long as there is no severe iron deficiency. So they may have a mild to moderate deficiency that allows for some room, but if they have a severe iron deficiency, I'm more likely to avoid it in that case. While doing all of that, it's important to keep tabs on the iron management and see what's happening with the iron levels. So we want to make sure we're maintaining some sort of balance. So we don't want patients to be severely iron deficient, but we also don't want to cause a worsening erythrocytosis by depleting iron. And so if they have a severe, significant iron deficiency with only no or mild erythrocytosis, like I mentioned in the previous slide, we can consider cautious PO repletion only if these specific scenarios are met. So ultimately, it is a individualized type of decision. So I always encourage colleagues to individualize care for the patient and their needs and their individual risk factors, their individual symptoms and scenarios. And I do counsel patients that a lot of this is not data-driven and more so an extrapolation from our understanding of secondary erythrocytosis from other causes and our understanding of testosterone. And ultimately, I use shared decision-making with the patient to arrive at the best clinical decision with clinical judgment and understanding of the patient's individual needs. And so now I'm going to move to the next half of my talk, which addresses estrogen and thrombosis, which is probably the bigger risk, bigger concern than the previous half of my talk. So a very quick background here. So the risk of thrombosis and venous thromboembolism with estrogen is relatively well established as opposed to testosterone where it is not. And there is a dose-dependent relation and a route-dependent relationship. So this is just a summary of some of the data that we have that looked at different doses of different formulations of estrogen. And we can see that there is a dose-dependent relationship and the risk can go up anywhere between 2 to 5-fold with different doses and formulations of estrogen. Estrogen may also cause what we call unusual sites of thrombosis, although this is a low absolute risk, but that means that they can sometimes develop thrombosis in unusual sites. So retinal vein thrombosis, cerebral venous sinus thrombosis, splanchnic venous thrombosis may also cause arterial thrombosis, but also a low absolute risk. So there may be an association with an increased risk of stroke, MI, and this was described in the 2 studies listed here. However, the absolute incidence of these events was low. And typically, the incidence of thromboembolic events with estrogen happens in the first 4 to 6 months of initiating therapy. So how does thrombosis occur with estrogen? So we still don't fully understand the mechanism, but very briefly here. So the green arrows are increased with estrogen, and the red arrows are decreases that occur with estrogen. So we do see that estrogen increases different procoagulant factors, including factor 12, factor 8, factor 10, factor 7, and it may decrease anticoagulant factors. So it may decrease antithrombin and protein S. At the same time, it may increase fibrinolysis to counterbalance that a little bit. But ultimately, the overall net effect we see is an increase in cross-linked fibrin clot formation. And that's in addition to its effect on platelet aggregation due to increases in von Willebrand factor, which are also ultimately going to lead to an increased risk of thrombosis. And what we do also know is that the recurrence rate after discontinuing estrogen is very low. So in those who develop a blood clot on estrogen, stopping estrogen does correlate with a low risk of recurrence, which is why generally those who do stop estrogen, we only anticoagulate for a finite period of time. At the same time, however, those who continue estrogen with therapeutic anticoagulation simultaneously. So the data we have is on cisgender women who are on hormonal contraception with estrogen-containing supplements. So if they continue anticoagulation, Martinelli et al. Analyzed data from the Einstein DVT and PE trials, and they found that the risk of VTA recurrence was not increased. In other words, if they continue the estrogen-containing supplement and maintain therapeutic anticoagulation, then the risk of thrombosis is low. So what about estrogen thrombosis in transgender patients? So the hematologic concern in this population is the risk of thromboembolism. And there's a lot of dilemmas and challenging questions that we really don't know how to objectively answer, but I will at least attempt to today. So if they have a prior history of an unprovoked VTE on therapeutic anticoagulation, can they start estrogen? Or if they have a provoked VTE and they're no longer on anticoagulation, should we restart anticoagulation if they want to start estrogen? What about those with a known thrombophilia, with or without prior VTE? What about those who develop a VTE after starting estrogen? What about those who have antiphospholipid antibodies or significant risk factors? So there's a lot of dilemmas that we always have to consider for the individual patient and their individual risk factors. So there's a little more data on transgender women than there is for transgender men. So, but it's mostly incidence data. So here's a summary I list here of 7 different studies where they looked at the incidence of venous and arterial thrombosis. And this is taken from a great review by the American Journal of Hematology in 2017, where, different studies found different incidences, but anywhere between 0 to 5 or 6% of venous thrombosis, and anywhere between 0 to 6% incidence of arterial thrombosis. And they highlight the time frame here and the type of estrogen used. And there's more recent studies. So there's 3 studies on transgender women that I'll briefly go over. So the study by Getahon et al. In 2018 looked at 2,800 trans women and followed them for 4 years. And they used cisgender men and women as the controls. And what they found was that there was a higher incidence of venous thromboembolism compared to both the reference men and the reference women. So this is the table below. And the relative risk was 4 to 16 between 2 to 8 years compared to reference men, and 3 to 13 compared to reference women. Now, this more detailed table looked at the hazard risks, and so first they had a overall cohort where they found an increased risk compared to reference women, but not reference men. And then they looked at those in the initiation cohort, so those who were followed after they started estrogen. And the significant findings here are in bold, but in general, there was a higher risk of venous thromboembolism after 2 years. There was a possible increased risk of ischemic stroke, but that occurred after 6 years. And there was no difference in MI. So it's kind of not very different from our understanding of estrogen in general, that it may increase all of these things, arterial or venous thrombosis, but more obviously venous thromboembolism. And these are the Kaplan-Meier graphs from that same study. So MI was not different, VTE is clearly different, and stroke initially was not, but after 6 years, that gap separated. Another couple studies that I'll briefly highlight. So there was a systematic review in 2019, and they identified a 2.3 per 1,000 person years incidence of venous thromboembolism, but they did note that there was significant heterogeneity in the data. So they concluded that transgender women have similar rates of venous thromboembolism as cisgender women who are on estrogen. But there was large heterogeneity, and so overall they recommended that more data and prospective studies are needed. And then a meta-analysis in 2021 that included 18 studies with 11,000 patients also had a similar kind of outcome. So prevalence of VTE was about 2%, and there was large heterogeneity in the available studies. So, and in addition to that, there's one study that looked at coagulation biochemical parameters, and that was published a couple of years ago. And they found that transgender women had increases in factor 11, factor 9, and a decrease in protein C. So all of these changes are procoagulant in nature. And this was more pronounced with oral versus transdermal and was worse with age. And so they concluded that the use of estradiol and anti-androgens resulted in a more procoagulant profile. Again, that is not surprising, as we already know that this is an effect of estrogen in general. But at least we have that specifically on a transgender population as well. So how do we manage that? Again, and I keep saying this, but it is important to recognize the lack of data, no current guidelines on anticoagulation management transgender patients, and it is largely extrapolated from cisgender women, keeping in mind that this is a different patient population and may have different types of venous thromboembolism and different patient outcomes. So in patients with venous thromboembolism after starting estrogen, if estrogen is continued, then continue anticoagulation. So these are the patients who started estrogen, then clotted after. Then we can continue anticoagulation with the presumption that similarly to those on hormonal contraception, that the rate of recurrence is probably low. However, if possible, it would be ideal to switch to a transdermal route, so a less thrombotic source, and if possible, to also lower the dose. And this is mainly because the risk with oral is likely higher. Now, one might argue, okay, but what if we switch to transdermal? Can we just stop anticoagulation because it's a lower risk? Again, it is very challenging to make that decision and determination with absent data. But my general approach is to continue anticoagulation even if they're on transdermal because of any possible small risk, unless if they have a high bleeding risk. Of course, as always, evaluate for other cardiovascular and thrombotic risk reduction for best outcomes. Now, in those with a prior thrombosis before wanting to start estrogen, so if they're already on anticoagulation due to an indefinite treatment regimen, then it's easier to make that decision to, okay, start estrogen because they're kind of protected. However, if they have a severe thrombophilia, if they have antiphospholipid syndrome, high risk factors, there is a possibility of anticoagulant failure when we add another thrombotic risk. So this is something to consider. Now, for those who were not on anticoagulation, so they had a provoked VTE, they stopped anticoagulation, now they want to start estrogen. Do we start estrogen and anticoagulation, or what do we do? And that is a more complex decision because we have to weigh the bleeding risks, we have to weigh the role of, or the route of administration. My general approach is if they wish to start oral, then I'm more likely to recommend restarting anticoagulation with the rationale that a previous provoking factor led to a blood clot. And now we are introducing another transient, or in this case, indefinite risk factor. So the assumption is that they might clot again when their body is put under another thrombotic challenge. In general, however, in that population, if they're low risk otherwise and they're using a transdermal estrogen, that would be my first recommendation. So consider transdermal, lower dose, and perhaps we could forego the use of anticoagulation because this is a long-term bleeding risk as well that we have to consider. So my preferred option is if they're willing to do transdermal, low dose, and avoid anticoagulation and be closely monitored, that may be optimal. Now, a common question that comes up is, okay, why don't we just, in those who are on estrogen, clotted afterwards, should we just stop the estrogen? In cisgender women who are on hormonal contraception, this is usually an easy decision. We stop it and we anticoagulate for 3 or 6 months, and then we stop the anticoagulation. Now, in transgender patients, there are several considerations. So first, the important one is the psychosocial impact of hormonal therapy and gender-affirming care. And it's important to have that conversation with the patient to understand their individual needs and how important it is for them. For some, it is extremely important to stay on it. For others, they might be willing to go off it, but it's important to have that conversation with the patient, understand their individual needs, their values in continuing estrogen, its impact on their well-being, quality of life, mental health, body image, and how strong is their desire to remain on it. Keeping in mind, however, that thrombosis and bleeding also has a negative psychological impact. So I do have patients who are in constant fear of developing another blood clot, or they're in constant fear of having a major bleed or hemorrhagic event because they're on lifelong anticoagulation. So even going the opposite route, so maintaining estrogen anticoagulation can have a negative psychological impact on patients. So it's important to understand where the patient's priorities and values and needs are. The other consideration is ongoing thrombotic risk. So it's most likely that maintaining therapeutic anticoagulation in patients who clotted on estrogen is probably effective, but again, this is an extrapolation. So is it possible that certain patients may have an anticoagulant failure? They're probably unlikely, but in those with severe thrombophilias, other risk factors, this is a consideration. In addition to that, the ongoing bleeding risk, and I think that's a major one. So in those on therapeutic anticoagulation indefinitely, they are at a lifelong risk of having a major bleed. So for as long as they're on an anticoagulant, they are at risk for a major bleed. And that's something important to explain to the patient, that this is going to subject them to potentially life-threatening hemorrhages. And so, you know, they have to be counseled on precautions, bleeding precautions, avoiding other blood-thinning things, agents, and so forth, in order to minimize that risk. And that on its own will lead to certain social changes. So things like athletic activity, occupational hazards, skiing, and so forth are going to be a challenge while on anticoagulation. So all in all of these above risks and benefits should be discussed with the patient. Options should be provided, and with shared decision-making, find ways to safely approach the best route to address all of these risks, concerns, but also the patient's individual needs. So to summarize that, so how I approach venous thrombosis in transgender patients on estrogen. So first, I evaluate their thrombotic risks, see if they have any additional or high thrombotic risks, and whether there's a concern for anticoagulant failure, which is uncommon. And then in those patients, I also evaluate for bleeding risks. So are they eligible to be on long-term anticoagulation, or do I have a concern for major bleeding events that may occur if they're maintained on lifelong anticoagulation? And then as well as occupational and lifestyle hazards that the patient is interested in. And after that, I aim to understand what the patient's individual needs and values are. So what is the importance they have and their desire for remaining on estrogen? Is it important for their quality of life, and how important it is for their mental health and body image and so forth? But also understanding their the psychological impact of thrombosis and bleeding that staying on the alternative route would have on them, and the social outcomes, social impacts. So, you know, they have to avoid high bleeding risk occupational lifestyle activities, avoiding medications that may increase bleeding risk, procedural planning, and so forth. So based on the above, I individualize care for the patient using shared decision-making to find ways to safely allow the patient to safely pursue their desire for hormonal therapy when possible. The majority of patients do have a strong desire to maintain hormonal therapy. And so for those who do wish to remain on estrogen, which are the vast majority, I generally continue anticoagulation indefinitely when it's indicated, find ways to safely allow estrogen treatment without causing thrombosis, so either by route or dose, minimize cardiovascular risks and thrombotic risk, but also minimize bleeding risk, and maintain regular follow-up. I do remind the patient that this is extrapolated data. It's mostly observation on low quality. So we may have an adverse thrombotic or bleeding outcome that happens with a theoretical or sort of experimental approach. And so it's important to be honest with our patients and also acknowledge these risks. So in summary, transgender patients on testosterone are at risk of erythrocytosis, which is dose dependent, but neither testosterone, neither testosterone and neither secondary erythrocytosis have been proven to cause thrombosis. Data is limited in transgender patients. Evaluate for alternative causes, pay attention to iron studies and symptom burden, and use shared decision-making to determine optimal TRT dosing, iron levels, and there's an unclear role of phlebotomy. And then in transgender women on estrogen, there are increased risk of thrombosis, possibly stroke, dose dependent. The management is complex, lacks data, and largely extrapolated and theoretical, but there are ways to allow for safe hormonal therapy with shared decision-making and use of anticoagulants after evaluating the patient for thrombotic and bleeding risks and the psychosocial impact of both. Thank you all for listening, and I'm happy to take any questions.
Thank you so much. I already have people texting me telling me that this is one of the best talks they've been to. So clearly
thank you.
You've got the right audience. But I know that we have a lot of questions. So let's get through them quickly here on the app. Do you think there's value in getting a ferritin before starting hormone therapy? Do you think universal iron deficiency screening with ferritin is on the horizon?
That's a great question. In our hematology clinic, everyone who walks in our clinic gets iron studies and ferritin. So to me, that's an obvious yes. But in the general population, that may not necessarily be the case. But I do think that those who want to start testosterone, I do think they are indicated to have a baseline iron studies, because they may have prior iron deficiency from back when they were menstruating. And we want to know where they're at now, and also what kind of effect testosterone is going to have long term. So is it going to cause them a new de novo iron deficiency? So yes, I would test them.
And I think you and I share a number of patients where, the iron deficiency develops. And so then we're sort of having this back and forth of, well, we've got to give them iron, but then we can't give too much iron. And then do we have to phlebotomize and sort of dog chasing the tail? One of the questions that I have about that, though, is a lot of people, I think, will use the hematocrit as a canary in the coal mine for, okay, I know I'm not giving too much testosterone because the hematocrit is less than 50. My concern with that is that it's not really canary in the coal mine if the canary is iron deficient. And so you're experiencing iron limited hematopoiesis. And really what's happening is they don't have enough iron. So the hematocrit isn't going up. And then they come in and they're like, I'm tired. I mean, we see this all the time in primary care, right? I'm tired. I just don't feel good. My legs are moving around. And then you check a ferritin and you're like, oh, it's 2. You know what I mean? I think that's another reason to think about that, is because I think you have to interpret the hematocrit in the context of their iron, right?
Absolutely.
Because if their hematocrit is 47 and you're like, that's fantastic. But like we saw in the case this morning, but their MCV is low, they're telling you they're not feeling great, and then you check that ferritin. So this is why it's really good to have a hematologist in your cell phone. Okay, anyone have issues getting DOACs covered for trans women? It's hard enough to get them covered for other indications. Wondering if continuing the estrogen is a barrier for insurance coverage.
That's a good question. Personally, I haven't had that problem, but it is a limited patient population. So on a broader scale nationwide, I don't know. I do anticipate that there may be limitations with insurance for specific types of scenarios.
Yeah, I haven't had that issue either, but that could be geographic. And then last question. Vaping use. What do you recommend with estrogen use? Do we have any data that correlates vaping with smoking?
Oh, that's a good question. As far as I know, as far as I'm aware, we don't really have any good data to understand the risks of vaping when it comes to thrombotic risk and its interaction with hormonal therapy. So I don't think it's something we know. I mean, if I were to guess, I don't think it's a significant risk. Of course, we do worry about the other effects of vaping that may, affect lung function, pneumonitis, things like that. But I don't know whether it's as far as I'm aware, there isn't any data that demonstrates a clear thrombotic risk from it.
Yeah. Well, thank you again so much. I know we were all really excited about that talk. And if you have any additional questions, you can go ahead and put them in the app and I can make sure that we can get them to Dr. Abu Ismail. And again, thank you so much for your time.
Yeah, thank you for having me.